Welcome to our Primetime Alive program, Skin Cancer. What is it? Who is at risk? Making the diagnosis and treatment options. I'm Vicki Newell, and I manage the Primetime Alive program at Mary Gridley Medical Center. As a reminder, if you want more information about Primetime Alive to sign up for a program, check us out at mgmc.org/PTA. Our presenter today is Dr. Leslie Christenson. Dr. Christenson is a board-certified dermatologist and Mohs micrographic surgery. She attended, it must be Mohs micrographic surgeon.
Yes.
There we go. She attended Iowa State for undergraduate education and the University of Iowa for medical school. Her professional training consisted of dermatology residency at the University of Iowa Hospitals and Clinics, a skin cancer research fellowship at Mayo Clinic, followed by a procedural dermatology and cutaneous oncology fellowship at Mayo Clinic. She worked as staff at Mayo Clinic for several years prior to moving to Ames with her husband and starting the first Mohs surgery department at McFarland Clinic. Her primary interests and practice emphasis revolve around aspects of skin cancer. She is a mom of 3 and married to Dr. Stuart Christenson, a familiar cardiologist to many, as well as a presenter here in the past for us. Please welcome Dr. Christenson.
Well, it is a privilege to be here. I see lots of familiar faces and they're all looking good, so that we're doing our job. This is great. So they did introduce me. We're going to talk about one of my favorite topics, and that's skin cancer. And those of you who know me know I love to talk, so we're combining my favorite topic with my ability to talk here. We are going to cover all these topics. But at the end, I also want to be a good listener. And that if you have questions, specific questions that you came with, I want to make sure that we have time to cover those and answer those, okay? If I start going too fast, or if you can't hear me, please give me a sign, okay? And we'll go from there. So we're going to talk about skin cancer. And when we talk about that, there's 2 main camps, okay? There's the non-melanoma skin cancer camp, and there's the melanoma camp. Within the non-melanoma camp, there's the basal cell carcinoma, the squamous cell carcinoma, and then there's a whole host of these things we call adnexal tumors, okay? So adnexa are the structures in the skin, like the hair follicles, the sweat glands, the oil glands. When those skin cells go awry, they can form cancers too. And they develop cancers that I think have beautiful names, even though they're not beautiful tumors, but like desmoplastic trichoepithelioma or microcystic adnexal carcinoma, you know, like you kind of get sing-songy. The most important thing, we're not going to cover all of those because we just don't have time, but it's important to know that they exist. And if you were ever to be diagnosed with one of those, you just want to make sure you're in the hands of someone who truly understands what these are and what needs to be done for them, okay? Now, the category of melanoma is made up of 1 diagnosis. I guess we thought it was that important that it got a category just all to itself, and that's the melanoma, and we'll talk about that later. So when we talk about non-melanoma skin cancer, we are talking about a very common group of diagnoses. Back in 2004, there were like 1 million of them diagnosed in the U.S. that year. But now, in 2018, okay, we're always slow on our data, but there's a question mark because it's probably between 5 million and 6 million diagnoses that were made that year. And it occurred in about 3 million people. So some of these people have more than 1, okay? The incidence is almost to an epidemic proportion. 1 in 5 Americans will have skin cancer. In Australia, it's 1 in 2, okay? So worldwide, the numbers get even larger sometimes. So the most common form of cancer. That, and the other thing is I looked this up just before I came because what's the cost to our healthcare dollars? Well, in 2018, there were $8.9 billion spent on the management and treatment of skin cancer. So if we don't kind of get this under wraps, I worry that Elon Musk may be giving us the hack too. So we got to get our act together here. The etiology is sun exposure, sun exposure, sun exposure. Now we can talk about climate change and we can talk about the ozone, but it really is us exposing ourselves to the sun. Okay, so we have to take some credit for that. There are those of us in this room that are more at risk than others, okay? And that we're more at risk to the damage of the UV light. And that's if we have fair skin, If we burn easy, and there's a whole debate of what about that intense intermittent sun exposure? I'm only out in the sun 1 week of each year, but I spend it on the beach and I get burned, versus I'm the farmer, I'm out in the sun every day, all the time, but I don't burn because I have this buildup. Well, both are risks. They just put you at risk for different types of skin cancer, actually. Okay, so that's kind of how that goes down. Tanning beds, I'm sorry, I can't say one good thing about them. Okay, so they do put us at risk. They don't build up a tan to protect us. Immune suppression. This is something that none of us choose. Okay, we're just kind of sometimes put in this category, and it does increase our risk of skin cancer. So if you've had a transplant and we have to suppress your immune system so you don't reject it, if you've had HIV, if you have CLL, even if it's not needing treatment, if it's in your past, that alters your immune system to the point that you're still at higher risk of skin cancer. These are things, like I said, you didn't choose, but you need to know that so we can manage it, okay? HPV infection, that's short for the wart virus, okay? These wart viruses, there's over 100 different ones out there, and they do put us at increased risk for skin cancer. There are some inherited diagnoses, like that BCNS stands for basal cell nevus syndrome. These people have a genetic mutation that makes them develop hundreds of basal cells, and it starts young in life. So thankfully, that's very few. Ionizing radiation, chronic wounds. The Marjolins ulcer is if you have a chronic wound on the lower leg, usually not from stasis, you know, from the swelling in our legs, but from other things that can put you at risk. Chemicals such as arsenic or tar. Now it seems like we're way past that, but I will tell you, I did see a patient in residency who had arsenic keratoses on the bottom of her feet. So she had to walk on these skin cancers, which was just very difficult. And then they did put ozone depletion up there because it does probably play a small role, okay? Now, not all skin cancers are created equal. So when you are sitting comparing notes about your skin cancers, you know, out and playing games, and one doc had you treat it one way and another doc had you treat it another way, it may be because it was a different type, it was a different subtype, it was in a different setting, and so everyone was treated properly, but they were just treated differently. So you have to kind of just have that background knowledge. So for basal cell carcinoma, this is the most common type of skin cancer, okay? It happens most commonly on the area that's exposed to the sun the most, our head and neck, okay? So this part, our nose gets burnt, our ears get burnt. This is what is often red, so that's where they occur. Now, the other thing you need to know is some of the folks in here haven't seen me just once. They've seen me twice or 3 times, right? You know, and that happens. And so 50% of people who get one will get a second within 2 to 3 years. And 75% of people who have 2 will get a third, because that same sun that caused one was hitting you elsewhere and can cause another. Doesn't mean that that same one came back, okay? It's just another one. So the subtypes, okay? There's the nodular ulcerative, there's the superficial, there's a pigmented, there's a morphiiform or a sclerosing, there's a micronodular, and there's a metatypical. Did you know there were so many basal cells? Yeah, so there are lots of different subtypes. This is what a classic nodular basal cell looks like. I'm showing it to you clinically where it's got that pearly raised border, and I'm also showing it to you what we look at like under the microscope. All these purple cells, this nodule here, they shouldn't be there, okay? You can see that arrow kind of going around them. So those do not belong. We want to get rid of those. They're just going to keep growing. Then we've got the superficial spreading type, and this can often look like psoriasis or eczema, or some people will think it's ringworm. It's just this scaly patch on the skin. And under the microscope, instead of that big ball, we've got normal epidermis here, but coming down off of it, you just got these little buds. But if we just let these little buds keep going, they're just going to spread out clinically and get bigger and bigger and bigger. Okay, so very different subtype. This is what a pigmented one looks like, and oftentimes people will confuse this with a mole or a seborrheic keratosis or a blackhead, all those kinds of things. And you notice that this is in darker skin. It can happen in darker skin, okay? And so something to be aware of. This is one that you might look at that cheek and be like, well, I don't really see anything wrong, you know, and this is where they kind of get tricky. But if you kind of look closely, do you see how this is a little bit of a whiter patch? And it's got a little bit of a sign called a biopsy sign right there. That little divot was where biopsy was done. And you just see it's very ill-defined. But if you were to feel this with your finger, it would feel kind of hard. And oftentimes people will come in with a spot like this and they'll say, it's a scar. A branch hit me here many, many years ago and it's just been this way ever since. Like we kind of explain it away. Under the microscope, it's one that is more aggressive and it tends to spread out farther than what we see. And you see, whoops. Let's see if we can go, oh, I just gave you these little strands, they just kind of, they're like roots, they just go out. And we have to track those out, make sure that those are all gone. These are the type that if you miss that, they love to come back, okay? So overall, these are slow growing. They bleed or ulcerate, that tells you it's a problem. They enlarge over months to years. There are some aggressive subtypes like we talked about, but they are capable of extensive tissue destruction, okay? There used to be a time when people were like, oh, is this really a cancer? I mean, it's not gonna kill you, you know? There are some basal cells, however, that do metastasize. I mean, we have so many of them nowadays that some of them do get very aggressive, especially in our immunosuppressed patients. And I would call this a cancer. This is really destroying someone's face, right? And this does then spread. And so you don't want it to ever become this. There's not a lot we can do at this stage, okay? So we want to get to it long, long before that. So it's important to be seen by your primary care doctor or to be seen by a dermatologist. And, you know, it's hard to get into a dermatologist, right? You know, I tell people all the time that when I wanted to go into dermatology, I was made fun of. I was told I wouldn't have a job when I got out, you know, because it was during the time of Bill Clinton and we were going to have all these gatekeepers and we weren't supposed to be specialists. But 3 friends of I became dermatologists from my medical school class, and we all practice in the state of Iowa still to this day, and we have no problem being busy. So, and there's just not enough of us, right? So we have to have some physician extenders, and that's fine, and they're good, but you want to make sure that they're supervised by a knowledgeable provider so that if they have a question, they can go and compare notes, okay? So that's what I recommend. Get in for an exam. We were talking earlier, sometimes it's hard to get in if you want that complete skin exam and you want to talk about your hair loss and you want to talk about, you know, your eczema or your psoriasis and your skin exam. That's too much. And then it's like 9 months to get in. But if you say, do you have any cancellations today? I have one spot I want you to look at. Sometimes you can get in a lot faster that way. So that's another approach, okay? And then, so they'll do the exam and they'll do a biopsy. It really does take a biopsy to know for sure it's skin cancer, even with the most trained eye, okay? There's some different treatments that we do for the different types of skin cancer and for the different subtypes. There's 2 big areas, the surgical approach and the non-surgical approach. Anything we can take care of with the non-surgical approach is wonderful, but once it's diagnosed as a skin cancer, it's harder. That's what we treat a lot of our pre-cancers with, okay? So within the surgical approach, we've got destruction, which is when we scrape and freeze or scrape and burn. We've got excisions, just a standard excision, and we've got the Mohs surgery. We're going to talk about all those different forms. Within the non-surgical, we've got this thing called PDT, which is photodynamic therapy. We've got topical therapies, such as Aldera and 5-fluorouracil. Those are creams. There is radiation. We're going to talk a little bit about that, cryotherapy, and laser, okay? So within the surgical category, Mohs is what we hear a lot about, and I'm going to come back and give that a little bit more time. But there are actually specific criteria. And if you don't fit these criteria, you don't qualify for Mohs surgery, okay? And so it either has to be on the head and neck, it needs to be recurrent, it needs to be an aggressive growth pattern subtype, it needs to have perineural invasion, or it needs to be larger than 2 centimeters. 2.2 centimeters is an inch, okay? So it needs to be that large. The 1-year recurrence rate on the basal cell for a face, you know, treated with Mohs surgery is 1%. It's a really good cure rate. Standard excision, we have to take a 4mm margin, so we can't just hug it. This is usually used for lower risk skin cancers, usually off the head and neck. So its cure rate, when we look at that, looks good, but if we use those more aggressive subtypes and we just treated them with excision, the cure rate wouldn't be as high. But it's a good cure rate for those that are chosen and selected that that's appropriate for. Now, this is kind of a little beef of mine because I see the recurrent ones. They should come to me, you know, so I see a biased. But if it's a positive margin, a lot of times people will be like, well, it looks great. it was a positive margin, but it's just a basal cell, so we're just going to watch it, you know? And that's a common thing that people will be told. But the recurrence rate in that case, if it's histologically positive, is about 27% versus a 6%, you know, risk of recurrence if it's a clear margin, okay? And so we do recommend that if it's positive, you get it treated, okay? Keratage and electrodesiccation is where we, for low-risk skin cancers, it's where we scrape the cancer. Can you imagine back to picturing those histologic slides that I showed you with those balls of tumor or those little ellipses of tumor coming down? We usually use this for the superficial type. They're very close to the top. We can numb them up and scrape those off. They don't like to stick together. They're not healthy cells, so they crumble away, okay? So it's a pretty good cure rate. It is operator dependent. I push hard, you know, when I'm doing this, and then I freeze. I don't burn, but it's very much the same. It's a destructive method, okay? The non-surgical, we've got the PDT, which is the photodynamic therapy. If you were treating an actual cancer with this, you bring them in, you numb them up, you scrape off what you see, you put this sensitizer on, you wait 2 hours, so it's taken up by the atypical or more rapidly growing cells, and then you put them in a light for 16 minutes and it kind of burns. And then you have to do this twice to get a 73% cure rate, okay? So it's a little bit tedious. It sounds great, like you're avoiding, you know, surgery, and it is great in the certain settings, but it's inferior to surgery overall. Cryotherapy, I've never done that for a skin cancer in my 26 years of treating skin cancer. I haven't done that yet. I use it a lot for precancers, but it is listed. Imiquimod, I have used that for small superficial skin cancers on a marathon runner's legs because they didn't want to stop to have surgery and to heal. And I thought, well, if it comes back, we're not out much, it's on their legs, you know? And that was a good cure rate, but they have to treat it for like 3 months to get the good cure rate. And the 5-fluorouracil is very similar. So kind of, they're there. We need to talk about them. We need to give them justice. There's always the right situation, but it's not very common. Surgery. Radiation gets a lot of press recently, okay? And so I want to talk to you guys a bit about radiation. I want you to be armed with this information. There is standard radiation, which is the brachytherapy and the external beam, you know, radiation. Those do have good cure rates, okay? But there's this superficial radiation that is really out in the news and on lots of commercials right now, and that's not the same, okay? And we don't recommend any of these as first line, okay? People say, oh, you can treat the skin cancer, you won't have a scar, it's gonna be better, but actually it's not. The cure rates are not near as high, and it's really hard to go back and do surgery in radiated skin, okay? So really be cautious. This is kind of a last ditch thing. The superficial radiation, it's 5 to 30 visits. Most surgery would be 1 to 2. The recurrence rate for a basal cell is up to 16%. With Mohs surgery, it's up to 2.5, okay? For recurrence rate for squamous cells, like, you know, 10 to 11%, that for Mohs is 3%. We only have follow-up on the superficial radiation for 1 to 3 years. We've got it much longer for the Mohs surgery. These are in studies. Overall, we've got it even longer, you know, but the studies on Mohs surgery are 5 to 10 years. There's absolutely no training on this in any residency or fellowship. There's no board certification in this type of radiation, guys. So you just need to be aware of that, okay? Whereas the other is trained and it's not just kind of on the side. Follow-up is important and prevention is important. You know, once you've had a diagnosis, we usually kind of have you follow up in 6 months and then once a year. Sun protection with your sunscreen's really important. There's all this talk about oral retinoids. That can be, it doesn't really help with the basal cells. It does with the squamous cells, and we'll talk about that in that category. Nicotinamide is a vitamin D derivative, and it has shown to maybe give you some prevention, okay? But that's actually, there's more and more studies coming out on that all the time. They say it does help, it doesn't help, it does help, so they're kind of back and forth, okay?
Is niacinamide the same as that?
Yes, but different than niacin.
Will you repeat what?
Yes, he asked if niacinamide is the same as nicotinamide. It is, but it is not the same as niacin. Those are we kind of get those all confused, yep. Squamous cell carcinoma is the second most common type of skin cancer. Once again, really does arise on that sun-damaged skin, most commonly on the face. It loves to also be on the back side of hands. A lot more of that HPV virus is involved in the development of squamous cell carcinoma, so it really likes lips and it loves hands. There are different subtypes of squamous cell carcinoma, just like there are for the basal cell carcinoma. So there's a keratoid canthoma type, there's a Bowen's type, there's a verrucous form, there's the well-differentiated, there's the acantholytic, the desmoplastic, the adenosquame, and the cystic, right? And some of these are more aggressive than others, once again. This is what a keratoid canthoma type squamous cell looks like. They kind of just tend to explode like a volcano. They just pop right up and you think, oh my gosh, it's going to eat my shoulder off, but then they just kind of stop. And what you see is what you get, okay? Some of these will even regress, but we still usually would treat this with surgery, okay? This is the Bowen's type, and you can see, wow, I mean, this histologically is very superficial. It's staying inside the top, every once in a while I get it to, it's staying inside the top layer here. Sorry about that, guys. I'm trying to get my pointer, but it just wants to. Okay, so it's staying inside that top layer of skin. It also looks, again, once like eczema or like a dry patch of skin or psoriasis, but it is a superficial form of squamous cell carcinoma. We often treat this with a scraping. The run-of-the-mill squamous cell carcinoma is really broken down into 3 subcategories, okay? And it's well-differentiated, moderately differentiated, and poorly differentiated. Well-differentiated isn't that aggressive. The poorly differentiated, with histologically, you can see in that bottom, maybe your bottom right, those are really cells that are just dissecting into the skin, and they love to travel, and you have a 20% risk of metastasis with a poorly differentiated squamous cell carcinoma. So we have to be very aggressive with our watch on those. Metastasis is more likely for squamous cells than basal cells. And if they have these characteristics, they are more likely. If they're a recurrent tumor, if they're larger than 2 centimeters, if they're deeper than 4 millimeters, if they're on mucosal sites or around your ears, those arising in chronic wounds tend to be more aggressive. If they have perineural invasion, meaning those cells are wrapping around little nerves in your skin, if they're poorly differentiated, like we talked about, and if you're an immunosuppressed host. So we're a little more aggressive with our treatment for those. Squamous cell does have a staging system, okay? Basal cell so rarely spreads that it doesn't have a staging system, but the squamous cell does, and we treat according to those staging systems. We always think of cancer. What stage is it, right? You know, and so there is a staging system for the squamous cell based on, once again, the tumor size, if it's poorly differentiated, if it has perineural invasion, and how deeply it invades. Once again, to make the diagnosis, go be seen by your physician, your dermatologist, get an exam, get a biopsy, go from there, okay? Once again, the surgical treatments are just the same. Some of these we would scrape and freeze. Some of these we would excise, but with a 6 millimeter margin instead of a 4 millimeter margin like the basal cell. And then once again, they have to fulfill certain criteria to qualify for the Mohs surgery within the surgical camp. When it comes to the non-surgical, less often that we treat these with topical things, okay? It's only the squamous cell carcinoma in situ or the precancers, the actinic keratoses that lead to these, that we would treat with these topical. Radiation, only if you are not a candidate for surgery, okay? There is a time, if we treat surgically and during that Mohs surgery we see that the tumor is wrapping around nerves, we clear it surgically, but we do worry about that, and then we will do radiation afterwards, just like they do for some breast cancers, for some prostate cancers. We add that radiation element to try to really make that cancer gone and take away the risk of it spreading, okay? So these are higher risk. They do have the risk to metastasize. The regular squamous cell, only a 4% risk. But if they have some of these higher risk factors, then they're a 20%, 30% risk of metastasis. If you were a high-risk tumor, we might do a sentinel lymph node biopsy and work with ears, nose, and throat doctors to get that done. We might do a superficial parotidectomy with that. There might be the post-op radiation like I discussed. There's even some chemo that we might add to really make sure that this is put to rest, okay? And some of the newer Agents out are not chemo, but they're immunomodulators like the PD-1 inhibitors, and they have fewer complications than the chemo, but they are having some huge successes in treating very aggressive skin cancers. Okay, so it's nice to have those. Once again, the follow-up is important every 6 to 12 months, every 3 months if it's high risk, sun protection. This is where topical retinoids don't decrease the risk of squamous cell, but oral retinoids do. We often use those in solid organ transplant recipients. That's what that SOTR stands for, okay? Nicotinamide has a higher rate of decreasing the incidence of squamous cell than basal cell, so up to 30%. Sometimes we'll do cyclic PDT to try to prevent people from having squamous cells. And so we do use those in our high-risk patients, not in our high-risk tumors, okay? So, why Mohs surgery? Why do I make a living out of just doing Mohs surgery, okay? Because that's a lot of what I do. And the reason for why we treat a lot of skin cancers with Mohs surgery is because it has the highest cure rate, 97 to 99%. We don't get to say that very often in any form of medicine, okay? Because bodies just don't let us. It spares healthy tissue. And those of you who have been with me know I think that that's really important, and we're going to use that. And so I have to come back a couple times, but I'm not going to go in and take a big piece if I can spare you some normal tissue. Then we evaluate all the surgical margins, so that allows us to have a high cure rate. And I'm going to give you a little bit more information on that. And it's cost effective. It's cost effective, okay? And we only use it for those people who actually qualify for it. So we try to manage it very tightly. If we were to do just a general excision, okay? We do this football shape, that dark area in the middle is your actual skin cancer. And we're going to check the margins on this standard excision. We slice it like a loaf of bread. Okay, and then we just take out some random pieces of that bread loaf, like that are shown here. And you see number 2 looks like it's clear. But if we would have taken from that area in B that shows the cancer going to the very edge, it would have been positive. But we didn't examine that section. When we bread loaf this or do a standard excision, we're looking at less than 1% of the margin. And that's why we like to do Mohs surgery, because then we're sectioning it like a leafy biscuit. You know, where you pull off layer after layer in a horizontal fashion, and we're examining all of that margin, okay? So we have a higher cure rate because we have a higher examination ability. Sometimes and oftentimes skin cancer is like the tip of an iceberg, right? And what we see is that little dot on the patient, right? You see that little dot, and what was actually there is that surgical defect, okay? And so that's why we would never know that unless we were tracking it out with the microscope. Once again, it is very cost effective. It's in the outpatient, setting. It's local anesthesia. The pathology read is included, and it's a lower recurrence rate. So we're not dealing with subsequent issues and subsequent costs. This is what we do. Some of you could tell you experiences here, but you come in, we look at the spot, I identify it, I draw right on the patient, we give you a mirror, we say, this is the spot we're going to treat, this is likely how we're going to repair it, we all agree, we numb you up, and then we use this curette. And I always call it like a sharp spoon instrument, and the cancer cells don't stick together, so we scrape, and it kind of defines where we need to take around. Then we cut right around that with our blade, okay? We put little markings on here, little hashes, with our knife, okay, with our blade, because we want to know what's up, down, right, and left. We want to know what we have to come back for if we see it on our section under the microscope. We remove that, and then we make a map. I have a card sitting right next to you, okay, on my surgical tray, and that's that card, and I lay that piece of tissue down on that card just as it was laying on you, just as it was a part of you, to keep my orientation, okay? Then we section that, or we ink it, okay? And I ink, maybe one part of that is red and one half blue. We number it, 1, 2, 3, 4. We lay it down in the tray. We know exactly what's 1, and we know 1 has a red edge and a blue edge, and we've made a map for that. I give this to my histotech. We call them the wizard behind the curtain, like in the Wizard of Oz, okay? So they're back in the lab. They freeze it. They embed it, and they freeze it. And then they put it in what's called this cryostat. It looks like a meat cutter, okay? And they're actually cranking like this, and every time they crank, it advances and they cut another slice. And then they put that slice, it's not meat thickness, it's like microns thick. They lay it on a microscope or on a slide, on a glass slide. That glass slide with those sections of tissue placed in a certain order are then go through the stainer and they stain it. Then we look at it under the microscope. And I put this picture up because this is the actual Dr. Mohs. This is Dr. Mohs looking at the microscope, the guy who designed this procedure. He was board certified in surgery and pathology. And he put this together at the University of Wisconsin. Okay, so on this first examination, piece number 1 had tumor, okay? And we're showing you those tumor cells there in that bottom right corner. Hard to see them at this magnification, but they're there. So what we do is we take our map back, we go back to the patient, we lay that right there, and we go back and we take more from that 12 o'clock to 3 o'clock position. We then process that, just like I showed you. This time it's clear, we're done, okay? Then, so once again, extremely high cure rate, but how do we put people back together? There's lots of different parts to that. The most surgery is just the removal and the examination. Then we go to the repair, okay? Usually the same doctor does that, but it doesn't have to be. It depends on your training. We may do something as simple as this. We let this heal by Mother Nature. And it healed really well. You know, it was very superficial. It healed great. We may do something where we just sew it side to side. Once again, healed great. We may do something more involved because it's too big to go side to side, and then we'll kind of borrow some skin, and this is a local flap where we rob Peter to pay Paul, okay? And this was just like rotated from back behind and rotated forward. Heals very well. Of course, we're only showing you the good ones, guys. You know, I mean, they're not all perfect, but we're showing you the good ones. Here's another one. You know, we're having to replace a kind of a nostril, and we're actually borrowing from the cheek, and that's hard for people to imagine, but we can use this crease because we can hide a scar there very nicely. And this one healed, once again, very nicely. If you look closely, you can see the scar, you know, but I have one nurse who says, no one should be in your wheelhouse that close except for your family members, you know, and so that's kind of what, this was a skin graft, okay, on the tip of a nose, a skin graft, also healed very nicely, but these are all the tools we have. Some get a little bit more involved. This is called a forehead flap, and so, you know, the defect here on the nose is not all that great up in that top left corner, but it's a huge percentage. And there was nothing that we could borrow to bring this together to make it look right in the end. So we actually borrowed skin from her forehead. And we took this, there's an artery right here, and we flip it down, we leave it attached to the artery for 3 weeks so that that artery can keep supplying nutrition to this skin down here and allow it to heal. Then when they come back in 3 weeks, as the one in the top right corner is showing you, we actually take that tube away, we sew it together here, we sew it together here, and then in follow-up you can see she looks great, okay? And so, but it's a very labor-intensive thing for the patient. You know, it's not really all that complicated for us, you might think it would be, but it's labor-intensive for the patient because you've got 3 weeks where you can't put glasses on. This elephant nose is in your way, you know, and your peripheral vision is really limited because every time you look, you've got this thing sticking out between your eyes, you know? So we don't like to do these things, but if that's what we have to do, we do them, okay? So once again, highest cure rate, that's why we do it. Leaves the smallest surgical defect, and sometimes that's really important because we want to minimize what kind of repair we have to do, and it's most cost effective, which is becoming increasingly important, okay? Going on to the melanoma, okay? That diagnosis that has its whole own category. This is the bad cancer that we think about. It's increased so much. You guys, in residency, you know, 25 years ago, I used to think, will I recognize it? Will I know it when it walks in? Because we didn't see it every day, you know? And now I see it every week, you know, and just those numbers have increased so much. It is the #1 cancer in women between the ages of 29 and 35. And we can talk about my hypothesis for maybe why that is, but it's scary. It is the 6th most common cancer diagnosis overall. It occurs in 1 in 49 men, 1 in 73 women. I just re-looked up these statistics because the 2025 Iowa cancer data just came out, just came into my email. Did you guys see that today? Yep, just came in. And so I was like, oh, I better check if I'm still, and it's unfortunately still the same. Iowa has the second highest rate of new cancers in the US among all the states. Melanoma is the 5th most common cancer in Iowa, okay? And so the melanoma incidence is actually still on the increase in Iowa. It's stable in most states, okay? I do think that part of this is because of we are one of like 6 or 8 states that don't have any legislation on tanning bed use in the young. There is a bill currently in the legislature that's going through. It's through subcommittee and through committee. It was just approved on the 20th in committee to limit tanning bed use in those younger than 18, okay? We've fought for this bill for many, many, many years. So we'll see if it goes anywhere. It has to get through the House and the Senate and signed by the governor. It's got a long ways to go, but we'll see. I'm hoping that the emphasis our government is trying to put on our cancer risk overall will maybe bring this bill to a heightened awareness. Once again, this happens mostly in our fair-skinned individuals, blonde hair, red hair, blue eyes, freckling, easy burns, but I have some people that don't even have any of that and they still have had a melanoma. Sun exposure, that intermittent sun exposure is probably greater risk than the chronic because a history of sunburns really puts you at risk. But look at the statistic. Tanning beds prior to the age of 35 increase your risk of melanoma by 75%. It just seems like a no-brainer, okay? But we all still love a tan and young people still love a tan. Family history, also there are some genetic markers that put us at risk for melanoma. Dysplastic nevi, that's atypical moles, and a large number of moles also put you at risk. Have you guys heard of the ABCDs? We talk about it a lot. Asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, which is the size of a number 2 pencil eraser put on, you know. If it breaks those, that's a risk for a melanoma. 25% of melanomas come from an existing mole, but 75% of them come from de novo, meaning they just develop, okay? This is breaking those rules. Do you see the two colors? So it has asymmetry, one half of it's not the same as the other. It has border irregularity, you see a little bit of that scallop. It has color variation, and we don't know the diameter. I'm guessing it's larger than 6 millimeters, but it really breaks those, so we would definitely biopsy this. This is the ugly duckling rule. Wow, that black spot stands out, doesn't it? Yeah, you'd be sending your husband or your loved one if you saw that to get that checked. Once again, sunlight is the cause. Once again, we make the diagnosis by going to our doctor, having an exam, and getting a biopsy. Melanoma also has stages, just like the squamous cell. We treat different stages differently. The earlier stages have a much better outcome, okay? The later stages, the survivals are not near as high. So we always want to catch this early. We treat this usually with an excision. We didn't used to treat this with Mohs surgery. We just used to treat it with a big excision margin. But there are new studies that are showing as long as we have a clear margin, we're good to go. So there are a lot of studies looking at the outcomes with Mohs surgery. What about if melanoma is metastatic? Is it a done deal then? It used to be. It used to be. But because of these immune modulators and because of some of these new genetic things that we have, like if it's a BRAF inhibitor, if it has a BRAF mutation, we treat them with a BRAF inhibitor, a MEK inhibitor. We might combine these. We might do a PD-1 inhibitor with a CTLA inhibitor. These are with oncologists. I don't do these guys, but I am in awe of them because they give good results. And I'm so glad for a team of doctors to work with to give these treatments and have better outcomes. Follow-up, once again, is important. I tell everyone, if you've had the diagnosis of melanoma, you've just bought yourself a dermatologist as a friend, because you need to come forever, okay? And so we're just going to be friends. And sun protection. Oftentimes people who have been given the diagnosis of melanoma, they kind of develop a fear of the sun. They're afraid to go to the next family picnic. You know, they're afraid to kind of be out there. They feel the sun and you kind of get a little fearful, it causes anxiety. We don't want that. We want you to be out, enjoy life, but we want you to be smart about it, wearing your sunscreen, your hat, your protective clothing. Be smart and enjoy, okay? It is crucial to prevent some of the exposure when we're young. Those of us in this room, we can't go back and undo anything we did, okay? You know, we just have to say, I enjoyed that summer. I enjoyed that boating experience, and now we're just gonna go from here. But it is important to tell our grandkids, yeah, if you don't want this scar like I have, you know, put that sunscreen on. They'll listen to you. That's important when it's a loved one telling them that, okay? And it is just important to also prevent them from getting those sunburns. Make sure they've got their sunscreen on. They're coming to boat or swim with you, make sure they have it. Wearing the sunscreen, wearing the protective clothing, the broad brim hat, avoiding the noonday sun, seeking shade, and never using a tanning bed. I can't say that enough. What sunscreen? I get asked this a lot. And I would tell you any sunscreen that you will use is better than the sunscreen in the glove compartment or just in your drawer at home, okay? So the most important thing is that you will use it, okay? A sunscreen with an SPF of 30 or higher, by definition, is what we want, okay? We want it to block UVA and UVB rays. And we're better at blocking UVB than UVA, okay? But the European sunscreens, they are better because they block more UVA. You need to apply it daily, 30 minutes prior to sun exposure, 1 to 2 fluid ounces if you're like in a bathing suit or if you're just with shorts but not a shirt, you need to apply a large volume. Don't forget your lips, the back of the ears, the back of the neck, or the back of the legs, and apply it. I had one doctor from Australia, said he told his patients to apply it like they were painting the wall in your home, and sometimes one coat doesn't get it, okay? Reapply every 2 to 4 hours when you're outside in the sun. So think about how much is in a bottle of sunscreen. I just told you to apply 1 to 2 fluid ounces. Most bottles are 36 ounces. If you think about a weekend application during the summer, 1 bottle is going to cover 2 to 3 people if you're applying it that quantity every, 2 to 3 hours, okay? 5 days, outdoors, beach vacation, 1 bottle, 1 person, okay? It really is that much. Okay, so when people ask me, can I reuse the bottle I had last year? I'm like, probably means you're not using it enough, right? Unless you just bought it at the very end of the season. This was a picture of my daughter. And my daughter still, she's now 17. She is still this pale. She's like, Mom, just don't get me the sunscreen that makes me look ghostly. I looked ghostly all my childhood. I don't want to look ghostly. And so we do have a sunscreen that she uses, but she is known as the pale kid with the blue eyes. I just hope she doesn't get a melanoma. She hopes she doesn't get wrinkles, right? So I've heard the issues about sunscreen that say, but I don't want it to burn my eyes. I don't want it to smell funny. It makes me hot. It gets streaky. I'm allergic. I tan through it anyway. I want my vitamin D. I'm not out in the sun. And I always say, none of those really carry that much weight with me because I think we should be able to work through all of those. Sunscreens have gotten so much better, so much better. So I tell people, keep trying. I think that the sun blocks are better than the sunscreen. They don't burn, they don't run, and you don't usually get a lot of color through them. Protective clothing. Okay, so this is my middle son. He's showing you his protective shirt. He wore them all the time until high school, and then he stopped. And there was nothing, he didn't care what I did or what pictures I brought home to show him. He still wasn't going to use it, but it is good to wear the sun protective clothing with the UPF in it. There's also some that are RIT dye that you can put into your favorite shirt if you just wash it. It doesn't have to be every time you wash it. It's just once every 10, washes or something like that. You kind of have to look at the instructions, and it puts a UPF in your shirt. A regular white t-shirt, only a sun protective factor of about 4. You're not getting much from that, okay? This is my oldest son. He's now 24 and in medical school, so he looks a lot different than this, but he's trying to show you a protective shirt, a protective hat, and sunscreen. This is the best way to leave the house, okay? So, and he burns really easily, so he actually follows that. He is not driven by that. We also want to just kind of wrap up in that you guys are all here trying to take care of yourselves. Like I said, we can't undo the sun exposure that we did. We can be smart about what it looks like. We can be smart about understanding what the doctors are telling us and how we're deciding on the best treatment at this stage. But we can also kind of give back and try to help the next generation and to contribute to some research dollars and some prevention. We have a Safe in the Sun run. It's also a walk. I'm going to show you the shirt from last year, okay? You know, and we like to promote that. I'm doing this with 2 other melanoma survivors. The Bliss Cancer Center is coming along beside us this year, and we're going to do a free skin cancer screening exams during this event. But it's just at Ada Hayden. It's a paved, flat surface, okay? You can walk the short circle if you want and just be a part of it. But it is to raise money, research dollars, and awareness of melanoma, okay? And you can just even follow us on Safe in the Sun Run at, @Ames on Instagram, and you can share that with your friends, okay? And just hopefully there'll be some good information there for you. We did this in 2023, again in 2024, and we've so far raised over $28,000 that we've given directly to the University of Iowa for their skin cancer, for their melanoma research. But we're hoping to keep some of that at home to support some of our melanoma patients here as well. Okay, so that's coming up May 3rd. The first May is Melanoma Awareness Month, so we try to do it then. Okay, so guys, I'm going to open up for questions. Yes?
You didn't say about spray versus lotion.
Great question. So from the neck down.
Will you repeat what?
Yes. Oh, thank you. I thought I would do that for sure. I was asked, what about sunscreen spray versus the lotion? So from a practical standpoint, it's much easier to spray. But you need to rub that in. And you need to make sure, you don't want to do it in an enclosed place. I always think garages with the door open are the best place because you're not getting the wind blowing your spray away. And you can rub it in, but it's also well ventilated. So that's the ideal. When I was taking my kids to all their sporting events, and you're going from the baseball game to the track meet, I would bring them next to the car, open up a car door, so I've got them blocked on both sides, and we would spray there to kind of protect the sun from blowing it away and rub it in. We went to a vacation in Mexico just last year, and I was mesmerized by the burn lines because you could tell people had sprayed and sprayed and sprayed, and you saw these curvy lines of white and then burn around the edges, and it had gotten blown away or it hadn't been rubbed in and it hadn't been evenly distributed. So I think sprays are very practical because people like to use them. I want you to have that sunscreen that you use, but you need to use it in a way it's not blowing away and rub it in. Okay? Yep.
I have 2 questions.
Yes.
First of all, it was diagnosed, I guess, by a pre-cancer, and I think it was a physician's assistant.
Yes.
Burned it.
Yes.
So is
Yes.
that probably almost 100% guaranteed to be okay?
Yes. So the question was, she was diagnosed with a pre-cancer, and it was burnt with liquid nitrogen. It's so cold it burns. That is absolutely the proper treatment. And what we always say is that, so when you go in and you've got kind of a red spot, won't go away. It's scaly, and it's a sharp scale, like a sandpaper scale that catches your finger. Those are often the actinic keratoses, is a technical term for them, and that is a pre-cancer. And we freeze those with liquid nitrogen when there's just a few of them. When your face kind of gets riddled with them, that's when we treat with a cream or that PDT to treat the whole area, okay? And yes, but if it comes back several months after the treatment with the liquid nitrogen, we encourage you to go back and be seen, okay?
I just have one other question about sunscreen.
Yes.
You can get the with moisturizer and also the tinted sunscreen. Is that okay?
Yes. We like it. So I was asked about the sunscreen, that you can get it in a moisturizer and you can get it tinted. And is that all okay? On a day in, day out situation, it's kind of easier for we women because we put moisturizers on our face. And so we can just make sure that the moisturizer we have has a sunscreen in it. And that really does cover us for kind of the day in, day out situation. Guys aren't as familiar with putting a daily moisturizer on your face. You know, it's like aftershave, but nobody likes to feel goopy, right? You know, and that's a guy, your skin is just a different porous material. So I'll give you a little bit of leniency there. But it is good to have just a daily moisturizer with a sunscreen in it. And it's good for the guys too, okay? Because then you just have the habit. I always tell people, you brush your teeth every day, you put your deodorant on, and you put your moisturizer with sunscreen on. The tinted is nice. My daughter, who doesn't want to look ghostly, she wears tinted sunscreen because she doesn't look ghostly. It's the good kind of sunscreen, usually with a mineral base, the titanium dioxide or the zinc oxide. But then that's the stuff that makes you look kind of white and ghosty. But they've tinted it so you don't look that way. So it's very nice.
Yeah, you don't have to put on makeup then.
And you don't have to put on makeup then, yeah. It kind of covers up some blemishes too. Yeah, Yep, it's all good, yes.
Are you going to be doing any surgeries at the new ASC?
Great question. So I was asked if we're going to do any of the surgeries at the new ASC. So that's debated, okay? There are certain criteria of surgeries that have to be out there. I would love to be out there. Some of our surgeries don't qualify. And that would actually, for our patients, increase the cost. When you're going from the hospital to the ASC, it brings costs down. When you're going from an outpatient clinic to the ASC, it can bring costs up. So we're trying to be very aware of that. Yep. Mm-hmm.
This is old school,
Yes.
definitely old school. When I was in elementary, and I even think sometime into junior high, I would get a fungus on my toes and on my fingers. And I would have to sit under a sun lamp, I forget how long, every night with sunglasses. And I've always wondered now if there's any connection, any studies that have been done or anything with something like that.
So the question was that when she was young, she would get a fungus on her hands and on her feet. And she would be treated by putting them in a sun lamp. And she would protect her eyes with sunglasses and sit there with the sun lamp on her hands and her feet. That's interesting. So yes, those probably did put you at higher risk for skin cancer on your hands and your feet if those sun lamps had legitimate ultraviolet light in them, okay? Today, similar, so we had some patients that had their acne many years ago treated with ultraviolet light, okay? And those people we know are at higher risk, and I see a lot of them. You know, they have kind of a little bit of a red blush to their skin and some fine blood vessels to their skin. Yes,
I'm shaking.
Yeah. She's like, I know that look. And so, and the skin is just a little bit thinner, a little bit more friable, a little translucent. That is from that exposure, and that does put you at higher risk for skin cancer. So we know that because of those acne patients that we've followed over time. Yes. Interestingly, now, today, guys, think about the young girls and all their fingernails. Oh, mercy. And they do all of their nails, and then they put their hands in these little ultraviolet things to fix them, okay? And my daughter even has one, and I said, now we're getting gloves for those hands of yours, you know? And so you can get gloves so that it just is the fingernail. She doesn't do it that often because she knows I'm concerned about that. So we just, moderation. I preach moderation with everything in life. My husband would teach you moderation with McDonald's, and I'm teaching you moderation with sun exposure, okay?
Check the keyboard, it's going to time out there.
Yes, thank you. Yes, that'll get to you. Yes.
I've had 3 Mohs surgery from Dr. Christenson on my face, and she does an excellent job, so don't ever be afraid to have her perform that specialized service. But I had on my shoulder just a little rash, just a little pink rash, and I was at my primary for a physical, and I just happened to say, what is this? And he looked at it and he said, you need to see your dermatologist, who was Dr. Meyer at the time here at Ames. And so I went to her, and it was melanoma. And so I always thought melanoma came from a mole, that's what you had to be watching for. So she did, it was in situ, so she was able to do in the office some surgery.
Yeah.
But I was really surprised by that.
You bring up a really good point. So to our listeners, she said that, she's had several skin cancers and they've been treated with the Mohs surgery, but she also thought she developed a little bit of a rash on her shoulder, and that she was seen by her primary care doctor, was sent to dermatology. Her dermatologist did a biopsy of that rash, and that rash was melanoma, okay? And it was an early version of it, the in situ type, and so it was treated with excision. Melanoma isn't always dark. It can be what they call amelanotic, which can look pink. And that gets complicated, doesn't it? And it's a little bit unnerving because you think, just when I know what to look for, now you're telling me I have to worry about my pink spots too, And so that is hard. That's a really good point that you bring up. But I think that what you noticed was this is new.
Mm-hmm.
This is changed. And you knew you were at risk for skin cancer and you saw something new or changing. And that's a really good clue that when you see something new or changing and it's persistent, it's not responding to the lotion you put on it, it needs to be seen. So I'm glad that's a really good point. Thank you for bringing that up. Yes, and then.
I have a question on what is referred to as the blue light treatment.
So the blue light treatment what I have been calling the PDT, or the photodynamic therapy, yes. And we call it the blue light treatment because, as I briefly and quickly described, that we often use it for the precancers, and we put on a photosensitizer, or it's called 5-aminolevulinic acid, okay? It's just a liquid, goes on your face, or on your arms or your hands, or whatever we're treating. And it sits there for 2 hours. There have been lots of different protocols over time, but it's kind of come to this 2-hour incubation. And that medicine is taken up into your cells that are more active, okay? Like the cancerous or the precancerous cells kind of metabolize more quickly. It's taken up by those a little bit preferentially. And then we put you in a light, and the light is blue, okay? If you were to look at it, you don't see it as blue, but it's on the blue spectrum. That spectrum is what activates that particular medicine most effectively. So you're in that for 6 minutes and 40 seconds, 16 minutes and 40 seconds. And that's the activation, and it kind of burns as that's being activated because we're trying to really activate that medicine in the cells and kill off those cells. So we kind of make them get really edematous and kind of explode, actually, if you were looking at it under and kill off those bad cells to let new good skin cells come back up.
To stay indoors out of sunlight for so many hours?
We do recommend that because not all the medicine is activated, so if you went out into the sun, it could hurt you. You'd be okay, but it will burn, so it won't be comfortable. Okay, yep. So then we tell you to really protect yourself from the sun, even the ultraviolet light, for the next 72 hours. And we commonly do those treatments during the winter so the light isn't as intense for you. Yeah. Yes.
With so many sunscreens out there, how do you know what specifically to look for? Is there certain patterns?
Yeah. So I was asked, with so many sunscreens out there, how do you know specifically what to look for? And that gets hard because I am not hired by any sunscreen brand, okay? I have gotten that question so many times that we actually put together a little brochure for my office. And we go through, if you have sensitive skin, if you want an efficient application, if you are a child, and so that we've kind of broken it down. And we've taken the feedback from patients, and we always take a little inventory from the staff, okay, when we put this together. And we update it every so many years because they're changing all the time. I really like Neutrogena as a brand. I find that people do well with it. We really like CeraVe. If you have sensitive skin, CeraVe is a good one. For those that want it to be cosmetically very aesthetically pleasing, okay? La Roche-Posay. Okay, and that's 3 separate words, but La Roche-Posay has a very nice tinted sunscreen. Okay, so if you were to ask me, Dr. Christenson, when you go, what do you buy? My children have been tortured over the years. Every year I would make them, we're going to try 5 new kinds, guys, and so they would put the sprays on and all the different things. They really always came back to liking the Neutrogena. It didn't burn, it didn't smell funny, didn't make them look like a baby, you know, like all and then, like I said, my daughter, the La Roche-Posay has really been what she likes to put on so she doesn't look ghostly, and it's got the tinted, you know. There are good chapstick ones, there are good stick ones. Sometimes the stick is what like a fisherman or a golfer wants because they don't want the grease on their hands when they're doing their activity. We try to be aware of that, okay? I always love this funny story with my son when he was in junior high baseball. He would not put on a sunscreen. I'm like, I'll take you. You can choose whatever sunscreen you want. Okay, so we went, and he went directly to this black spray that said sunscreen for men. Okay, he's like, you know, he's 13 years old, you know, and he used that, and every kid on the baseball team wanted to use his sunscreen for men. Like, you know, it was black, it was like, you know, a little bit more sophisticated, you know. It's just, what will they use? And that was, it was interesting, yeah, to see that. But yes, those are the brands that I find, and we find consistently patients appreciate.
Okay, so I need to know, is it 30, 50, 70%?
Yes.
What am I looking for?
So the question was, is it 30, 50, 70? What are we looking for? And what really is recommended? And you've heard all of the things of like, if you go from 30 to 50 or from 50 to 70, you're really not getting that much more protection. So let me break this down for you. When they do the testing to give that number of an SPF of 30, an SPF of 50 or whatever, they are putting a shot glass volume of sunscreen on your body, okay? If we don't put that much on, so that gets the 30 and that blocks over 90%. Have we lost our time?
I just want you to touch the screen.
Okay.
Sorry. Thank you.
If we put on, so if we put on that much, we're blocking like 97% of the rays for a 30. But the problem is, if we don't put that much on, and we're starting with a 30, now we're protecting less. If we start with a 50, we still have some legitimate protection. If we start with a 70, we have a little bit more. So it's not giving you permission to put less volume on because it's that streaky paint, right? You know, that I've described, and you can burn on the spots that aren't covered. But that volume, that's where the higher SPF comes in and helpful. You know, so I usually get like a 70 for my kids when we're at the lake, you know, because I know how much volume is going to go on and that's going to be more protective than a 30. But if you were to like scientifically look at them and put the right volume on, it's not giving you that much more protection. But that's where the little caveat is. Does that make sense?
That's perfect. Yeah.
Yes. Okay. Yes.
What about light therapy or phototherapy? Any thoughts on that?
Yes.
Is that a problem or?
No. So if you are getting light therapy, like ultraviolet therapy for like psoriasis or dermatitis, is that what you're asking?
No, I can buy a little light, you know, and get like an hour of sunlight to
Yes.
avoid SAD, if you will, or whatever.
So it depends on the light. If you are doing a mood light, those are fabulous. They do not have ultraviolet.
It depends on the mood then, I guess.
It does. They do not have ultraviolet light in them.
I have one without ultraviolet.
Yes. If you buy one of those that has like a visible light spectrum that still affects our serotonin release, you know, I'm all for those. When you go and get one of those that has the ultraviolet light in it, then you are putting yourself at risk. Yeah. Good question.
If one has had recurrent basal and or squamous,
Yes.
but it's been more than 5 years,
Yes.
should one still go?
That's a great question. So the question was, when one has had recurrent basal cell or even recurrent squamous cell, but it's been now 5 years without a recurrence, do you still need to go to the dermatologist? And to that, I would say less frequently. Like maybe you go and be seen once every other year or once every third year. The American Cancer Society says over the age of 50, they recommend that you go, you know, every 2 to 3 years, but you don't have to go all the time, like not every 6 months to every year. Yeah, and I'm going to tell you, because of the limitations of the dermatologist, a little bit of judicious use is good, but not to ever be like, I'm done with that chapter. You know, I don't ever need to go back. That might be a little bit much, you know, but if you want to check in, you know, every 2 years, every 3 years, you're like, I see nothing, every 5 years, you know, just to kind of keep a little bit of a connection, okay? When you get past every 2 years, you drop off their patient list, then you're like back in as a new patient. So if you want to keep that contact in case you have a problem, keep it every 2 years, okay?
Thank you for that.
Yeah, a little tip. Okay.
Any other questions? Lots of very good questions.
Really good questions. They helped with it. Were there any questions that were from the remote or from the?
There weren't a few
Okay.
minutes ago, so
Perfect,
no.
perfect. Okay, excellent.
Well, thank you, Dr. Christensen.
Yes, thank you.
Such a wide range of skin cancers, I mean, and lots of great information. Your handouts are wonderful, lots of really good information in there as well. And just remember, we do record these. We'll share the recording with you as well if you want to watch it again or share it with somebody else. So I want to remind those who are here in person, you have an evaluation, so please fill that out. Also give us suggestions for other topics or presenters that you'd like to hear from. I want to remind you of our upcoming programs. We're actually back here tomorrow afternoon, 2 o'clock, and the program is on coronary artery disease. And then our next program after that is Wednesday, March 12th, and that is on celebrating National Nutrition Month, on talking about food connects us. And then Wednesday, March 26th, it's an update in colorectal screening. So you should have all those at home. You can sign up for them online. Love to have you here. Please, thank you for joining us online. Thank you again, Dr. Christensen. A great program. There's a basket right over there that you can drop your surveys in and drop your pens off if you don't want those. But thank you for joining us and have a great day.
Great.